You found yourself admitted into the ICU, for whatever reason. Let's hope that never happens. Okay, someone else is admitted into the ICU. Imagine you get to see it in their perspective. You got a breathing tube in you, you're groggy, you can hear many things happening all at once, machines beeping, voices chattering, and they think they're ready to pull your tube out the minute they call your name. You start to blink cooperatively. That, my friend, is the wonderful Dexmedetomidine at work. Join us to learn about this fascinating drug and how it works. This is Mastering Anaesthesia, so let's go.
Hello everyone and welcome back to Mastering Anesthesia. Today we're going to talk about Dexmedetomidine. Let's get to know a little bit about this amazing drug. It is basically a very highly selective, specific and potent alpha-2 adrenergic receptor agonist. Quick revision on adrenergic receptors to freshen up our memories. We have alpha and beta adrenergic receptors. Alpha adrenergic receptor can further be subdivided into alpha-1 and alpha-2. Alpha-1, which is a G protein coupled receptor with a GQ alpha subunit. The stimulation will activate phospholipase C, which will break down the phospholipid bilayer into inositol triphosphate and diacylglycerol. So what will this result in? There will be vasoconstriction, there will be relaxation of the GI smooth muscle, there is salivary secretion, and also glycogenolysis. And what does alpha-2 adrenergic receptor does? Alpha-2 adrenergic receptor is a G protein coupled receptor with a GI alpha subunit. So the stimulation will inhibit adenylyl cyclase. This will result in platelet aggregation as well as the release of noradrenaline from autonomic nerves. So dexmedetomidine, they are 7 to 10 times more selective for alpha-2 receptors. What's unique to dexmedetomidine is the quality of the sedation is like a sleep-like state, unlike the sedation that can be seen with propofol, midazolam, sodium thiopental that acts on GABA. So the distinction comes from where the alpha-2 adrenergic receptors are located in the central nervous system and peripheral nervous system. So they are densely located in the pontine of the locus ceruleus, where this is associated with the wakefulness of the patient. So by stimulating this part of the alpha-2 receptors, it induces a sleep-like state, unlike GABA receptor where it promotes widespread CNS depression. That is why you see in midazolam and propofol, patient will wake up groggy, difficult to arouse. So this is in stark difference with dexmedetomidine, where when you wake the patient up, patient will immediately able to blink and respond to your question. Other locations are located in medullospinal tracts, rostral, ventrolateral medulla, and the dorsal horn of the spinal cord. Remember also that dexmedetomidine has analgesic properties as well. Right, now let's go to detailed description of dexmedetomidine. So for any drug that needs to be described, we should have a system. So I usually would use chemical uses presentation, followed by action, dose, onset, route of administration, side effects, everything else including toxic effects, and then goes on to describe about its distribution, absorption, metabolism, and excretion. Now, interesting chemistry fact about dexmedetomidine. That is, dexmedetomidine is the S isomer of medetomidine. Note that the R isomer of medetomidine has no activity. As for its uses, dexmedetomidine is commonly used in the ICU. It is used to produce light to moderate sedation. And this is according to the protocol of your local guideline, where in Malaysia, we usually aim for light sedation using Richmond Agitation Sedation Score from -2 to +1. With patient, we want them to be awake, calm, and comfortable. We also use dexmedetomidine for procedural sedation. We use it for imaging, you use it for procedure. It is very convenient because it rarely causes respiratory depression. Number 3, dexmedetomidine can also be used for balanced general anesthesia, which is a type of anesthesia where we administer small targeted doses of multiple medications, typically hypnotic, opioid, and muscle relaxant, to avoid significant side effects from using large doses of a single drug, faster recovery time, stable vital signs, and by the concomitant use of dexmedetomidine will aid in achieving this balanced general anesthesia. How does it help? It helps by attenuating hemodynamic response towards tracheal intubation by reduction in the plasma catecholamine during anesthesia, and it reduces the requirement of inhaled anesthetic and opioid. Okay, as for its presentation, it is presented as colorless solution in vials containing 100 micrograms per ml, and in each vial there can have 2 ml. So in a vial it can contain 200 microgram, and it typically is diluted to a preparation of 4 to 8 microgram per ml. And as for the dose, it is different according to our target. If you're targeting for sedation in ICU, initial rates of 0.7 microgram per kilo per hour, and later maintaining with a concentration of zero point 0.2 up to 1.4 microgram per kilo per hour to achieve sedation, and try to titrate it to effect. If you are targeting for general anesthesia, we would load the patient at a dose of 1 microgram per kilo per hour for 10 minutes, then continue on with infusion at zero point 0.2 to zero point 0.6 microgram per kilo per hour. This is with the use of other standard GA medications. But if you're using dexmedetomidine as a sole agent for general anesthesia, the dose would be significantly higher at a 5 to 10 microgram per kilo per hour. Now moving on to its mechanism of action. How does dexmedetomidine produces its sleep-like sedation? So it starts off with its highly selective nature for alpha-2 receptor. Remember that alpha-2 receptors, they are a G protein coupled receptor with a specific GI alpha subunit, and they are located presynaptically. Now, this alpha-2 stimulation will inhibit the release of noradrenaline at the locus coeruleus at the pons, which is linked to the natural sleep pathway, and this ultimately will lead to sedation. With that clear, now we can talk about pharmacodynamics. We're going into systems by systems. First system would be to the central nervous system, as stated before. It causes sedation and also anxiolysis, and it is more like physiological sleep, which can be demonstrated by the electroencephalogram. The dexmedetomidine drug also causes less delirium upon awakening. This is in stark contrast with other sedatives that act on GABA receptors. Added advantage of using dexmedetomidine is it doubles as an analgesia, so it has an action in the substantia gelatinosa of the dorsal horn of the spinal cord, hence reduces receptor transmission of pain signal. On to cardiovascular system. Interestingly, it has a biphasic effect. What I mean by this is there is an initial phase of hypertension seen due to the action of dexmedetomidine on alpha 2b receptors located specifically at vascular smooth muscle, causing vasoconstriction. So when blood vessels constrict, there will be hypertension. Following this brief phase, then comes the hypotension and bradycardia. This is due to the reduction in the central noradrenaline release. So reduction in sympathetic drive, hence hypotension and also bradycardia. Next system is the respiratory system. Theoretically speaking, there is no respiratory impairment, and airway should remain patent. And as a bonus, dexmedetomidine also acts as a decongestant and antisyllagogue, which is especially useful if you are going to use this for awake fiber optic intubation. As for its pharmacokinetics, dexmedetomidine is given IV. As for its absorption, if given orally, the bioavailability is unpredictable and can be as low as less than 20% of bioavailability. And this bioavailability can be increased by giving it buccally we can increase up to more than 75%. As for its distribution, it is highly protein bound at a value of 94%. However, it still easily crosses the blood-brain barrier, easily crosses the brain, and has a large volume of distribution at 118 liters. This is due to the high lipid solubility of dexmedetomidine, making it easy to disperse and diffuse into cell membranes and lipid bilayers. Dexmedetomidine is metabolized both in phase 1 and phase 2. Phase 1, it is hydroxylated, whereas in phase 2, dexmedetomidine undergoes glucuronidation and methylation to make it more water soluble so it can be excreted. As for its excretion, the distribution of half-life is 6 minutes. This means it takes this short of a time period for it to distribute from the central circulation to highly perfused areas of the body, such as the brain, where it is intended for its action. So its rapid onset is due to its short distribution half-life. Next, its elimination half-life is 2 hours. This is the time required for the total amount of drug to reduce by 50% during the terminal phase. And lastly, its clearance is at 40 liters per hour. That is the volume of plasma completely cleared of dexmedetomidine per unit time, which is hour, by the removing organ, and in this case, primarily the liver. And this value is important for us to calculate its maintenance dose.
Thank you for watching. If you find these videos helpful, please hit the like and subscribe button to show your support. Comment down below what topic you want us to cover next. Till next time, see you in the next video.